So hello, good morning, good afternoon and good evening to all our speakers, chairs and the wonderful audiences in different parts of the world. Welcome to ACNS Webinars. The speaker for the first session of today is our honorable guest from the USA, Professor Mohammad Abdalkader. Dr. Abdalkader is a board certified diagnostic and interventional neuroradiologist at the Boston Medical Center and an associate professor of radiology at the Boston University Chobanian Avedissian School of Medicine. His clinical practice is focused on imaging and performing neuroendovascular procedures in patients with acute stroke, intracranial aneurysms, intracranial stenting, carotid stenting, endovascular treatment of AVMs, AV fistula, vertebroplasty, kyphoplasty, and endovascular treatment of pulsatile tinnitus. He is an noted author who has over 250 publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to be a speaker at our webinars, and today he will be talking about venous sinus diverticulum in patients with pulsatile tinnitus. The speaker for the second session of today is our very honorable guest from China, Professor Xin Zan. Dr. Zan is an associate chief surgeon, associate professor, specializes in skull-based surgery in the Department of Neurosurgery, West China School of Medicine, West China Hospital, Sichuan University, China. So he is an active member of the IFNE committee, member of the Neurosurgical Youth Committee of Chinese Congress of Neurological Surgeons, and committee member of the skull-based surgery branch of the China International Exchange and Promotive Association of Medical and Healthcare. He has received several honors for his outstanding contribution to neurosurgery in his country, and we are extremely honored to have him today at our webinars as a speaker. And today we will be talking about combined microscopic and endoscopic resection of Spheno-Petro-Clival Meningiomas. The chair for the second session of today's webinar is an honorable faculty from Japan, Professor Takashi Sugawara. Professor Sugawara is a professor of neurosurgery at the International University of Health and Welfare, Narita Hospital. His clinical interests are focused upon skull-based surgery and craniofacial surgery. He is an important member of the Japan Neurosurgical Society and has published several articles in leading journals and book chapters. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs and the wonderful audiences to this online platform of ACNS Webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. Professor Abdalkader, you may start your presentation, please.
Well, thank you for the invitation. It's a great honor to be with you today. So we're gonna discuss the venous aneurysm or venous sinus diverticulum. There's a lot of misunderstanding about this, but it's very commonly seen in patients with pulsatile tinnitus. So we're gonna go. So as you know, pulsatile tinnitus is very common, and venous causes are the most common causes of pulsatile tinnitus. They're usually due to either structural or flow abnormalities of the venous structures adjacent to the ears. They are often under-recognized and unfortunately underreported. So we generally divide the venous cause of pulsatile tinnitus in three big categories. One related to the lateral sinus, which is the combination of the transverse and the sigmoid sinuses. The second category is the emissary vein abnormalities, and the third category is the jugular vein anomalies. Now, for the lateral sinus pathologies, the transverse sinus stenosis is by far the most common and can be divided between patients with intracranial hypertension or without intracranial hypertension. The second category under lateral sinus pathology is the sigmoid sinus wall anomalies, which can be divided between sigmoid sinus diverticulum and sigmoid plate dehiscence. So diverticulum is basically the outpouching or the bulging of the sigmoid sinus into the adjacent mastoid air cells. Usually there is associated dehiscence of the sigmoid plate, and the protrusion is usually laterally projecting into the sigmoid bone, mastoid bone, or even the skull. There are a lot of outstanding questions regarding the etiology of it and how do you classify it, and most importantly, how do we treat it. As you can see here, this is a 3D angiogram, reconstructed angiogram showing the venous outpouching. This is this transverse and the sigmoid sinus. So this is a typical case of venous diverticulum. Now, regarding etiologies, there are two theories or mechanisms about how can we have or patients have venous diverticulum. The first theory is that diverticulum is usually or considered as a remnant of embryological sinus called the petrosquamous sinus. And this is, for example, an angiogram incidentally showing outpouching of the sigmoid sinus. The patient did not have any whooshing sound or pulsatile tinnitus. There's no stenosis, so this could be considered as congenital in nature. And so this is another patient with a large, very large diverticulum. As you can see here, this is the sigmoid sinus, and this is the protrusion through the mastoid air cell and the temporal or squamous bone of the temporal skull. And this also was seen incidentally in this patient undergoing a CAT scan for a different reason. This is another example showing the connection with the petrosquamous sinus. For example, you can see here, this is a venogram. This is a big catheter in the transverse sinus, and you can see here this outpouching at the junction between the transverse and the sigmoid sinus. As you can see here at the top of this outpouching, there's this vein that goes run horizontally below or beneath the temporal lobe. And this patient also, as you can see here, has like significant stenosis. So after we treated the stenosis with stenting, we were able to get through a microcatheter through the bulging that you can see the skull base indentation of it. And you can see the microcatheter tip inside this petrosquamous vein. And you can see here the contrast injecting. So basically this is the lateral sinus where you can see the stent, this is the outpouching, and this is the connection with this petrosquamous vein. So the venous diverticulum can be congenital and can be connected to the petrosquamous vein. In our practice, and especially with patients with pulsatile tinnitus, we strongly think that the venous diverticulum is a secondary finding, and usually we see it very often in patients with venous stenosis, and we do believe that the venous diverticulum is related to flow turbulence and the irregularity of the venous flow just downstream to the stenosis. And as you can see in this picture here, that after stenosis you will have increased velocity, there will be increased shear wall stress along the sigmoid bone, and there will be secondary erosion of the bone causing the venous outpouching. And this has been demonstrated through multiple computational flow dynamic studies. As you can see here, this patient showing the venous stenosis with the significant increase of the velocity, as well as the increased shear wall stress with those red patches here where there is the sigmoid plate. And usually after stenting, you will restore, this is the computational flow dynamic. After stenting, you see restoration of the blood flow, resolution of the normalization of the velocity, and resolution of the shear wall stress. And this is similar to even the venous flow is relatively low compared to the arterial flow, but if there is increased flow on the same spot for a very long time, this may lead to erosion, as you can see in this picture, that if 50 years of erosions compared to 25 or 15 years of erosion, if a single drop of water dropping, it's going to really create this a groove or dehiscence, and that will eventually bulge and cause the diverticulum. So we do, as I said, we do believe that venous diverticulum are acquired lesion, and we can very commonly and very frequently see it in patients with stenosis. This is an MRI of patient presenting with right-sided pulsatile tinnitus. You can clearly see the right transverse sinus stenosis here, and this is the MRI post-contrast. If you look to the native images, the fast spin echo imaging, you can see that where the stenosis area, there's exactly a streak of faster flow, as you can see this dark signal. So this is basically on the regular MRI, you can see the streak of flow. This corresponds to increased velocity, and it's hitting exactly where the diverticulum is. And this is also in the MRA, and usually on the MRA, as you know, we don't see arterial venous flow unless the venous flow is arterialized. So this is an MRA of the head. You can see the faster flow in exactly where the stenosis is, and it's sitting on the sigmoid plate. This is just another example showing the right transverse sinus stenosis. Again, this is a patient presenting with right-sided pulsatile tinnitus. You can see the venous stenosis here, and you can see the venous diverticulum. And if you look to the fast spin echo, you can see the turbulence of the flow and the increased flow velocity with the streak of the fast flow hitting on where the diverticulum is. So this is a very interesting case that this patient presented to us with a venous, with right-sided pulsatile tinnitus as well. And as you can see here, she presented in 2020. You can clearly see here that there's the sigmoid plate dehiscence and there's the venous diverticulum. This lady happened to have in our institution a regular CT scan in the setting of trauma 13 years before the presentation. And you can see here they are not exact quality, but you definitely can tell that back in during this exam, the sigmoid plate was intact here. So this is another a clear evidence that venous diverticulum can be acquired or secondary. This patient was obese, and over the 10 years period, she eroded the sigmoid plate and then resulted into venous diverticulum. So this is another evidence that venous diverticulum are usually acquired in nature in patients with pulsatile tinnitus. And in our experience, like almost every single, or actually every single venous diverticulum that in symptomatic patient presenting with pulsatile tinnitus, whenever we see the diverticulum, there's almost always associated stenosis next to them. Those are each one of them is completely different patient. You can see intrinsic stenosis here. You can see extrinsic stenosis here. Here mixed intrinsic and extrinsic stenosis here. So with every single diverticulum that you can see here, there's associated venous stenosis. Those are also lateral views for another set of patient. You can see also like there's venous stenosis here, and there's this venous diverticulum, venous stenosis, and venous diverticulum. So this is another evidence that in every single diverticulum that we treated or we found, there was associated venous stenosis. So after the etiopathogenesis, we're gonna discuss a little bit about the management about venous sinus diverticulum. So how can we treat those a patient? This is the patient that presented with like around like 13 to 15 years history of pulsatile tinnitus. You can clearly see the stenosis and the diverticulum. This is a 3D volume rendering reconstruction of a venous phase of an angiogram. And this is, we decided to treat. This patient had idiopathic thrombocytopenic purpura, so we decided to just treat. We did not want to start her on dual antiplatelets and place a stent here, so we decided just to treat the diverticulum first. And effectively, the diverticulum was treated, and the treatment was similar to a brain aneurysm. We catheterized with a microcatheter and placed coil, detached a few coils here, as you can see, with very good occlusion of the diverticulum. Remember that we did not want to stent the stenosis because the patient was having idiopathic thrombocytopenic purpura, and we did not want to start her on blood thinners. However, even though the diverticulum was treated very well, the patient did not have a consistent improvement of the symptoms, and unfortunately her symptoms recurred the next morning. So we decided, because her symptoms were very disabling, we decided to bring her back and to treat the stenosis. And it was really very interesting to see the change of morphology of the stenosis. As you can see here, the stenosis was a little bit more, looks like more extrinsic, something compressing from outside. But then when we repeated 1 week later or a few days later, we can see that it's now more like round filling defect, and this is more intrinsic stenosis. And in our experience, we do think that intrinsic stenosis, since they've been there for a longer time, we do think that they are more likely to be associated with venous diverticulum. So here you can see the venous diverticulum treated, and you can see the intrinsic stenosis. So just because of the severe or moderate to severe stenosis here, we decided to place a stent, as you can see here. And now here you have the venous stenosis treated and the venous diverticulum treated. And if you look carefully here, you can see that this arachnoid degranulation that you can see here, it's pushed back and compressed here outside of the stent. So fortunately, after the second procedure, the patient's symptoms completely resolved after almost 15 years of suffering. So this is actually another evidence that, that even with the pathogenesis or the etiopathogenesis of the sound, not only the diverticulum, but the whooshing sound in the ears, you don't only have to treat the diverticulum, you have to treat the turbulence of the flow resulting from the stenosis. This is just another example. This is a lady. You can see clearly the sigmoid plate dehiscence here. You can see the venous diverticulum eroding completely the skull base. And this is the MRI showing T2 hyperintensity arachnoid granulation and the transverse sinus adjacent to it. We also treated this patient with, initially we did not treat the stenosis in this patient. So we just treated the venous diverticulum, as you can see here, but this patient had some improvement, but her symptoms recurred. As you can see here, the baseline, there's definitely some stenosis. We initially was hesitant to treat because we know that it was arachnoid granulation, but the patient symptoms just improved for a little bit, and we had to treat her with Diamox just to for her symptoms to improve. So this is a very important message again, that the treatment of the diverticulum alone is not enough to resolve pulsatile tinnitus of those patients. Those patients should be treated either with stenting or with aggressive medical treatment if they have intracranial hypertension or severe stenosis. This is another example of venous stenosis and a large venous diverticulum. This lady also presented with right-sided pulsatile tinnitus. She actually also had a contralateral venous stenosis, and there was another diverticulum on the other side, so bilateral diverticulum. You can see very nicely here the two round filling defect across the transverse sinus, and there's the huge diverticulum on this patient. You can see it even on the skull X-ray. You can see the indentation of the diverticulum over the mastoid air cells here. You can, on the AP view, you can see the intrinsic stenosis. You can see the diverticulum. Just because of the very large size of the diverticulum, we treated the stenosis first, and then we treated the diverticulum with coining, and the patient symptoms completely resolved. This is another angiogram showing like the turbulence of the flow. This is not like the fancy computational flow dynamics. This is just the flow dynamic. You can see here, this is a young lady with intracranial hypertension. The catheter is in the proximal transverse sinus, and you can see the venous diverticulum here. And this is the angiogram or the venogram showing the turbulence of the flow. You can just focus on this area and see the turbulence of the flow and how it's hitting along and causing this venous diverticulum. For this patient, just because of the significant stenosis, even though it's not extrinsic, it's something sitting inside, so it's intrinsic stenosis, we treated with a long stent followed by coiling of the venous diverticulum. So the question then arises, do we really have to treat the diverticulum? Can we just treat the stenosis if we're saying that the stenosis is the cause of the problem of the diverticulum and is the source of the noise or the pulsatile tinnitus? Can we just treat the stenosis? And this is in this patient. You can see this patient presented also with pulsatile tinnitus. You can see there's severe stenosis here and there's the diverticulum. So we treated the stenosis, and as you can see here, the stenosis was very severe, and the stent did really great job with complete recanalization of the blood flow, and you can see how the blood flow is being restored here. Just because of the significant improvement of the flow, we decided for this case not to treat the diverticulum. It was really very interesting, even though here we were able to go inside the diverticulum, but decided not to treat it. And very interestingly, following this patient 3 months later, you can see here, this is the CT scan, baseline CAT scan without the stent, and you can see the diverticulum here, and you can see the dehiscence. The 3 months follow-up after stenting, you can see the stent here. This is the 3 months follow-up. You can see along the diverticulum and along the dehiscence, there is a new bone growth. So that was really very interesting, and we noticed here that it's really, you don't even have to treat it, but there is bone regrowth and bone remodeling. So this is really another evidence that those dehiscence and diverticulum in this lesion are secondary lesion. If you treat the primary problem here, you don't have to treat the diverticulum, and bone may grow back. This is just another example. So this patient also had stenosis. This is coronal view. You can see here the small diverticulum. You can see the dehiscence are just treated with stenting, and you can see how the bone grow back along the diverticulum. So this is another clear evidence of the bone remodeling after treating just the stenosis without the dedicated treatment of the diverticulum. This is also another example. You can see here this patient also presented with right-sided pulsatile tinnitus. You can see the stent was placed, and look at the sigmoid plate here, how it was thin here before and how did it grow back, and it's significantly thick after the stenting alone without treatment of the dehiscence. And this is very this is just a 3 to 6 months follow-up. Sorry, we just came back here. This is just another example showing the stenting here and this diverticulum and the small dehiscence here. You can see how the bone grow back in this region. So we looked back to all our patients who get stented and did baseline CT scan and baseline and follow-up CT scan. And very interestingly, we found out of 15 patients who satisfied our inclusion criteria that up to 80 plus percent of those patients, 13 out of the 15 patients, had growth of the sigmoid plate and the sigmoid diverticulum on the follow-up imaging. This just recently published last week, actually, in the Journal of Neurointerventional Surgery. So then the question is, do we really need to treat the diverticulum? So treatment of the diverticulum is very important to look at it from different perspective, other than the etiopathogenesis of it. But obviously, sometimes it's complicated, right? Going through those stents, this may be complicated by protrusion of the coil loop, especially that, when you treat they put the stent and then you go through the stent. So like this patient, the coils start going outside, but also cost. The cost is very important. Those coils that we place here, they are very expensive, right? So do we really need to treat? The other important consideration to keep in mind that those diverticulum sometimes may be large and may necessitate like more complex and more time to treat those diverticulum. This is just another example. You can see we place the stent, but then the coils start protruding and entangling and going outside of the stent. So we ended up placing another stent. So sometimes treating the diverticulum may not be very easy. And that's really the important here, that do we really have to treat those diverticulum? So we looked back to our all patients with sigmoid sinus wall anomalies, whether it's dehiscence or diverticulum, and looked to the patient who underwent transverse sinus stenosis. And we divided those patients between patients who were just treated for transverse sinus stenosis, just with stenting, without treating their sigmoid sinus wall anomalies, and compare them to those patients who get treatment of both transverse sinus stenosis with stenting and the sigmoid sinus wall anomalies. And very interestingly, we did not find any difference between patients who did receive dedicated treatment of the sigmoid sinus wall anomaly and those who did not receive. So basically, independent of you treat the sigmoid sinus wall anomalies or not, treating the stenosis alone was enough to cure the tinnitus in those patients. So basically, we concluded in those patients that you just have to treat the stenosis and you don't necessarily need dedicated treatment of the sigmoid sinus wall anomalies. And this was also published in Journal of Neurointerventional Surgery, and showing stenting alone resolved pulsatile tinnitus in patient with transverse sinus stenosis and sigmoid sinus wall anomalies. So when we consider treatment or dedicated treatment of venous sinus diverticulum, again, this is a very evolving field, so we don't really know, we don't have a lot of data and we don't have more prospective studies. But in our opinion, we do think that treatment of the diverticulum should be considered if the diverticulum is very large and saccular in shape, not diffusiform in shape, and when it's large enough to cause erosion of the skull base. And in that case, we can consider treating the diverticulum, or if the diverticulum was associated with dehiscence. And I'm going to show you this case. So this is one of the cases that, apologize. So this is one of the cases that we just decided to treat. Obviously, you can see here there's dehiscence and there's small diverticulum. So initially decided just to treat the stenosis. As you can see here, this is the stenosis here. We placed stent with good restoration of the flow, and we did not do any dedicated treatment of the diverticulum. And 6 months later, the patient is back with a pulsatile tinnitus. So her symptoms came back. And as you can see here, that the stent was very well placed, the diverticulum is here, and there's dehiscence. So this patient, it's not only the diverticulum is really the missing bone along the sigmoid plate. You can see what we call the air on sinus sign, right? So the sinus is here, the air is direct in contact of it. So for this patient, even I do strongly believe that the diverticulum was not the cause, it's just the dehiscence of the bone here. So we decided to bring her back to retreat. And I initially wanted to place coiling, right? And as you can expect, the coiling were coming all over the place just because the diverticulum was very big. So even though I was coming from the contralateral side through the right transverse sinus, left transverse sinus, and trying to put coil here, but the coil were not behaving well. So then if you can do, you can see those reconstructed images. I really wanted just to close this window here, and the way I treated for this case, I placed a web device, and you can see the web device here. So I decided to put a small web device across the dehiscence here, and basically this is the via microcatheter crossing the stent, and this is the web device sitting exactly on the window of the dehiscence. So basically here we treated the dehiscence, not necessarily the diverticulum. And this is the two X-ray images, the 2D images. You see that the web is sitting exactly here, and this is the web after the thrombectomy, after the stenting. And you can see here that we did not really treat the diverticulum, we just placed the web device across the dehiscence, and the patient's symptoms completely resolved after the procedure. The last few slides, so in our experience, we treated like a little bit more than 26 diverticulum now in 23 patients over 4 to 5 years. And among the diverticulum, 20 of those diverticulum were saccular in nature, but there are like 6 patients who had fusiform dilatation, not like saccular like this. And all of them had stenosis, either intrinsic, extrinsic, or mixed stenosis. And we reported our preliminary result last year in interventional neuroradiology. As I mentioned that we were just doing coining, then we switched to stent-assisted coining, but nowadays we're mainly using stenting alone, and especially for patients with post-stenotic dilatation or fusiform dilatation and not saccular aneurysm. So again, we initially started with just coining, but most of those recurred. So we switched to stent-assisted coining with great results, but then switched more to stenting approach just to treat, especially if it's a fusiform dilatation of the diverticulum. So in summary or in conclusion, venous sinus diverticulum is common in patients with pulsatile tinnitus. You should always look for associated stenosis. Treating the stenosis is essential, and treating of the stenosis is more important than dedicated treatment of the diverticulum. And dedicated treatment of the diverticulum may not be even necessary. And thank you very much for your attention.
Well, thank you very much. It was really interesting, something very new to us, so very fascinating. I would like to congratulate you for bringing out these beautiful techniques to us. And a few questions that we would like to put across to you is that how long would you give blood thinners in these patients with stent?
Well, most of those patients, they don't have thrombosis, actually, just stenosis. I think we exclude the patient with thrombosis, but if you're talking about stenosis, we usually do 7 to 10 days before, 1 to 3 months after with dual antiplatelets, and then 1 to 2 years with single antiplatelet.
Okay, that's very interesting. But another very important thing I would like to ask you, because pardon my ignorance, because pulsatile tinnitus is a subjective feeling. Is there any way to quantify it objectively?
Yeah, there have been some of our colleagues that are doing direct, I think one of the computational flow dynamics that I showed you, they can generate the sound out of it. They also can do a little bit fancy stethoscope to hear, but it's not very common in, our routine clinical practice. But unfortunately, it's totally subjective. I totally agree with you. It's subjective. But what we've noticed, and I did not mention that in my talk, that almost all of those patients with venous stenosis / venous diverticulum, their noise will improve when they compress on their jugular vein, right? So this is one very objective way to tell if this is really their noise is venous in nature if they respond upon jugular vein compression. So this is one of the hint that will tell you, well, their symptoms are real and their symptoms is venous in nature.
Right. So there are several case reports at least of people who are undergoing microvascular decompression for tinnitus. So in these patients there may be an incidental neurovascular conflict also. In such cases, how do you arrive? Like, is there some test to differentiate?
Yeah, no, that's really great question. I'm not a neurosurgeon, but I think we do see as neuroradiologists, we do see a lot then, neurovascular conflicts. We see it on imaging. We see um, for us, if there is any other pathology that can explain the symptoms, then this would be the most likely cause of the symptom, right? Like, let's just say if we see neurovascular conflict, with the, ICA or, any CPA, and the patient has at the same time transverse sinus stenosis, we do believe that this transverse sinus stenosis is most likely to be the cause of the symptoms. And at the same time, we exhaust all investigation, and we even do an angiogram just to make sure that those patients, they don't have fistula. And it depends on the conflict, right? So sometimes if the neurovascular conflict is very high in suspicion, we do advanced imaging to see, like, the root entry zone enhancement or the atrophy of the. So, but in our experience, many of those neurovascular conflicts are probably incidental.
Thank you. Thank you very much again. We have Ben from Hong Kong who has raised his hand. Yes, Ben.
Yes, hello, Professor Mohammed, and I really congratulate on your result and for this particular interesting pathology. Because I also have sharing by other neurosurgeons about this pathology. So in your case series, so there is some recurrence after the stenting. So I would like to ask whether you have think about the pathophysiology of the pulsatile tinnitus. So would that be caused by the diverticulum or the sigmoid sinus wall dehiscence causing the tinnitus? Because I'm aware that in some neurosurgeons, they would perform the cement repair for the dehiscence, and they said that the recurrence rate for the pulsatile tinnitus is really low. So I'm not an expert on this, but I would like to know about your opinion, because treating this diverticulum is mainly based on the series according to your talk. So based on the patient symptoms to see the treatment response. So I would like to ask about what do you think about the pathophysiologies of the response? Is it related to the diverticulum itself, or is it related to the sinus wall dehiscence itself? Thank you so much.
Thank you. Yeah, no, that's obviously the most important question is, and as I showed that, in my opinion, that you have, like, if you think about it, you have to have generation of the noise, which I do think the generation of the noise, the source of the noise is the turbulence of the flow, right? Then you have to have a window, a breakdown into the pathways for this noise to get to the inner ear, right? So in my opinion, that you can, and I always, when I see patients, I tell them, like, as if you are living in your apartment and you are next to a highway. If your windows are very well sealed, right, even if there is traffic outside, you may not hear noise, right? Or even if your window is very open, even the minor noise outside, you may hear it, right? So I do think it's, it's like you have the generation of the sound by the turbulence of the flow of the transverse stenosis. This has to be transmitted through a dehiscent bone. Now, this dehiscence can be with or without diverticulum. And as I showed you with the case that I put the web, I did not treat the diverticulum. We treated the stenosis. Patient had persistent symptoms, and the dehiscence was still there. I treated just the dehiscence, but not the diverticulum, and the symptoms completely disappear. So I agree with you. I think if the three conditions are present, the transverse sinus stenosis, the diverticulum, and the dehiscence, then we may need to treat at least two of them to break the cycle, right? And that's why I showed, like, even with patient with transverse sinus stenosis and just diverticulum, if they don't have dehiscence, then you may just have to treat the stenosis and you don't have to treat the diverticulum, right? So I think the way I understand it, that you just really, and that's why I totally agree with you. Our surgery colleague, they really have a great result with the resurfacing, with the cement, because they are fortifying, they're strengthening their window, right? So if you put like a lot of cement, then patient, yes, may not have the symptoms anymore, But this is very important because those patients may still have the stenosis, which may be due to intracranial hypertension, which may have other repercussions, visual problems, headache. And this is why a lot of the surgical literature about just treating the dehiscence with bone without investigating for transverse sinus stenosis, for intracranial hypertension, yes, you can cure their noise by putting cement across the sigmoid plate, but you may miss their underlying pathology, which is the intracranial hypertension that resulted in transverse sinus stenosis, right? So, and I have, and even in the surgical, unfortunately, a lot of surgical, they just do a CT temporal bones, right? And a lot of those patients, they are middle-aged women, obese. They just they have tinnitus. They may just present with tinnitus initially. They have tinnitus. They go to the ENT. They put cement. They fix the bone. But those patients, they did not treat their stenosis, they did not treat their headache, they did not treat the potential visual repercussion. So I think, so that's why, even though I agree that treating the bone alone may fix the noise, but you really have to investigate for those patients that to miss the intracranial hypertension that resulted in the transverse sinus stenosis. But in summary, I think breaking this cycle from the generation of the noise to the turbulence of the flow to the transmission of the flow, any treatment of this may be helpful to treat. And just one more thing, I showed you one patient that we treated just the diverticulum, and we treated her stenosis with just medication with Diamox, and Diamox is known to treat those patients with IIH.
Yes, and that's the second question that I like to ask about. So in your case series, in how many of those patients having those symptoms like the pulsatile tinnitus will have concurrent intracranial hypertension? Yeah, that's my second question, and it's really an interesting topic, and for this to think about this.
Yeah, as I said, literally every single patient with diverticulum, they have a transverse sinus stenosis. That's a transverse sinus stenosis. And transverse sinus stenosis is very well known, very sensitive and specific. It's been reported to be present up to 93 or 96% of patients with IIH. Now, not all patients obviously they have pulsatile tinnitus, but not all of them they have the full clinical representation of intracranial hypertension. I don't really remember that on top of my head the percentage of patients with full intracranial hypertension, and the reason we did not really comment, we did describe it, but for patient coming to us, and this is very important, not all patients coming to us coming through neurologist and getting the full evaluation with lumbar puncture, spinal tap. So right by the modified Dandy criteria, you have to have lumbar puncture to formally diagnose them with IIH. So basically, a lot of my patients coming through the ENT clinic or the coming to me just because I have pulsatile tinnitus. Now, retrospectively, they may have some blurry vision, but not all of them, they underwent the full investigation for intracranial hypertension. So basically, when they are presenting to us just with pulsatile tinnitus and they don't have headache or they don't have visual problem, we don't get a lumbar puncture on them. We just examine them for papilledema if they have it or not. But to go back to your questions, all of the patients they have transverse sinus stenosis, not all of them have been fully investigated for intracranial hypertension, but and this is the last comment that I have. Intracranial hypertension is a spectrum, right? And it's spectrum. Not all the patients will have the full imaging or clinical criteria to have it, right? So I do believe that if those patients they are and the demographics of IIH, like, middle-aged, childbearing age, women, obese or overweight, and they have transverse sinus stenosis, I do believe they all have a mild spectrum of intracranial hypertension, even though if they don't have like the papilledema or the high opening pressure on the investigations.
Thank you so much,
Thank
and
you.
congratulations again.
Yes, Dr. Liu, would you like to ask any questions?
Thank you, Prof, for a very nice topic. Now we know that there's another reason for pulsatile tinnitus. May I ask, in your treatment algorithm, between using stenting and also coiling, or probably a web device that you show, do you make a decision whether they are dominant or non-dominant venous sinus, or whether now is non-dominant venous sinus is simpler to put in a coil or web device rather than a stenting? Does it make a difference? My second question, Professor, is regarding in the venous structure, how many stent can we put in if compared to arterial structure? Is there any limit? Whether the arterial, sometimes we put double stenting, whether it's safe to do the same if you want to treat the stenosis. My last question, Professor, you did talk about pathophysiology, and we know that venous stenosis may also lead to AVF. Do you think that both diverticular and AVF share the same pathophysiology? Thank you, Professor.
Yeah, thank you. So regarding your first question is, as you noticed, most of our patients their diverticulum is on the right side where it's dominant venous sinus. So we definitely, and since we think that it's more flow related, it does make sense. Even though few patients, that the one that I showed was large, they may have diverticulum on the other sides. We strongly, there's only, I think, only one patient out of like many patients that I had to treat both diverticulum. So in our experience, it's probably not necessary to target both diverticulum if they are present. So it's rare to have both on this on both sides, but even if it's present, it's rarely it's not usually necessary to treat it. So that's regarding the dominance, but most of them, the majority of them, they are on the right side where it's usually 70% dominance. Now, regarding your second question about the number of stents, yes. Unfortunately, a lot of if those patients have intracranial hypertension, they may present later with juxta-stent stenosis, right, when the stent is short. And for those, we extend the stent with putting another stent. The longest or the highest number that I use is 3 stent, like overlap the stent to cover from the torcula, or actually from the superior sagittal sinus all the way to the sigmoid. We did not have any problem. I think the main concern is if you put many stents or more than one stent, are you gonna create more like, occlusion of the vein of Fabry, or, impair the venous drainage into the lateral sinus? There have been at least 2 or 3 studies showing that even if you put like closed cell stent, or even like, I'm not sure if it looked to different multiple stents, but we actually don't worry about covering the vein of Fabry. Almost all the cases, the vein lavae is exactly where the stenosis is, right? And we cover it all the time without any problem. So, and for all the cases that, and even one of them that I showed you, the chordal protrusion outside of the stent, we placed 2 stents and there was any problem. So even though the data is limited, but I don't think really there will be a problem from overlapping many stents to treat complication or to treat its new stenosis or juxta-stent stenosis adjacent to it. Now, regarding your third question, which is the overlap between the dural arteriovenous fistula and as I said, all the cases that we published and we treated with stenting, they really actually only one patient had venous thrombosis, not like venous stenosis. She had like high risk factor. She has like very severe. We treated with stenting. Now, stenosis and IIH, I don't think we have not seen any associated fistula if the pathology is the stenosis and not a thrombosis of the vein with clot there. But as you said, it's very well known that venous thrombosis may be complicated with new vasculature and new dural fistula formation. I have not seen it. There's only one case report that I'm aware of, that a new fistula has formed after stenting, right? So on the baseline, there was no fistula, and then they did the stent for stenosis, and then on the follow-up, they found a fistula. I'm not really sure if that was not seen before, it was there and was not seen, or was some injury and caused the stenosis, but I don't really think that there is any relation between the pathogenesis of the fistula and the pathogenesis of the diverticulum. because the pathogenesis of the fistula in the setting of thrombosis is neovasculature, that very tiny, that will open up in the setting of thrombosis, but it's not like macro flow dynamic changes that will lead to the erosion, right? It's micro, not macro. So that's why I don't really believe that there is overlap or there is common pathogenesis of the dural arteriovenous fistula and the venous diverticulum.
Thank you very much, Professor.
Thank you very much. If Prof. Sugawara, would you like to ask something? It's a very interesting topic.
Yes, thank you very much for very interesting pathology. And my question is, can this diverticulum make bleeding to the air cell or to intracranial space?
Yeah, thank you for asking this question. Actually, I should have commented on that. A lot of my patients, they will ask this question actually, right? Because they think that this is an arterial aneurysm. So it's really very, very important. As far as we know, and I don't believe there's anything in the literature that any of those diverticulum has ruptured and caused bleeding in the brain. So I think it's really very important to differentiate. That's why I try to avoid calling it aneurysm, and patients will all like, freak out. Oh, this is a brain aneurysm, right? So I think it's completely separate and completely different than arterial aneurysm that we all know and treat, and there's completely different natural history and risk. So for venous diverticulum, they are and that's why we call them diverticulum, because like we do think that like in GI tract we call like intestine diverticulum, to try to differentiate them from true aneurysm, because as far as we know and as far as it's been reported, there's none of the risk of bleeding on those lesions. And they are really within the sinus, they go inside the bone, so they are very well surrounded by thick structures.
Right. Thank you.
So, and that means the treatment indication is like for the prevent the increasing the intracranial pressure. I mean the cure the stenosis, not for the divertical. I mean, what the treatment indication for this disease?
Yeah, so as I showed the very few slides, we sometimes see venous diverticulum when we're reading, imaging like, MRI or CAT scan for any other reasons. We can see diverticulum. We definitely should not treat. So the treatment indication is for symptomatic patients, right? Like they have to have symptoms related to this finding. And as I showed that most of those patients, or all those patients actually, they have associated symptomatic patients. So whenever we see diverticulum in symptomatic patient, they tend to have associated stenosis, right? So venous diverticulum should not be treated and should not be considered a high risk lesion if the patient does not have ipsilateral symptoms, right? So that's why in our and unfortunately I did not mention this in my slides. I'm following up 5 symptomatic diverticulum patients with diverticulum said, well, I'm not bothered by my noise. Is it dangerous, doctor? I said, no, it's not dangerous. It's not like arterial aneurysm. So we've been watching them conservatively, like, with that. And 3 of them, their symptoms disappeared on follow-up, right? They lost weight or they start, treatment of IIH. So that's why we only treat patients with symptoms, and those symptoms should be severe enough and not responding to medical treatment, which could include weight loss, GLP agonist, or Diamox or intracranial hypertension. So only severely symptomatic lesion that did not respond to medical treatment should be considered for treatment.
So your symptom in the tinnitus, right?
Yeah. That's also a very important question. We don't know. We don't know if this diverticulum or the bone dehiscence has anything related to the 3 things actually. We don't know any, or we're not sure about a relation with headache, right? Like I showed the remodeling, and so this could be related to headache, but it's very difficult because headache is so non-specific. We don't know if it's related to non-pulsatile tinnitus. A lot of those patients, especially presenting with intracranial hypertension, they may describe a hissing sound, a high-pitched sound that we really don't know if, it's has something to do with the non-pulsatile tinnitus, and the dizziness, right? We know, like, the hissings of the superior semicircular canal, or they may present with dizziness. So it's very unknown about we know the relation with the pulsatile tinnitus, but not the other symptomatology.
Thank you. Thank you very much.
Okay, so thank you very much, Prof. Abdalkader. That was wonderful, and it is really a new era of endovascular treatment, and we have like diagnosis of such rare symptoms and new pathologies coming up. We are extremely grateful to you for letting us know about all this and newer modalities of treatment. Thank you very much. So before we move on to the second session, I would like to mention that we broadcast this on WeChat, YouTube and Zoom, and as of now we have around 730 people live on all the three channels combined. So thank you very much. We'll move on to the second session, and I'll hand this podium over to our second chair, Professor Sugawara, to say a short introduction, and invite Professor Xin Zan for his lecture. Professor Sugawara.
Okay, so the next speaker is Dr. Xin Zan. He's gonna give us a talk about combined microscopic and endoscopic resection of Spheno-Petro-Clival Meningiomas. This surgery is a very complex coverage surgery, so we must be able to learn a lot from his lecture. So, can you ready? Are you ready?
Yeah, I'm ready. Thank you for the introduction, Professor Sugawara and Raja. And it's a great honor for me to be here to share my experience with the combined microscopic and endoscopic resection of Spheno-Petro-Clival meningiomas, its feasibility and technical nuances. I have nothing to declare. At first, I want to briefly introduce my hospital. It's a West China hospital, Sichuan University. It's located in Chengdu, Sichuan province. And Chengdu is located in the west part of China. It's known as a land of abundance for 2,000 years. Mostly due to the Dujiangyan irrigation system, people were free from floods, droughts, and famines. And thus Chengdu has long been a key economic and cultural center for ancient Chinese civilization. And the West China Hospital ranks #1 in the STAN ranking of Chinese hospitals since 2019. And for decades, it has been ranked the second best hospital in China. And the neurosurgery department was being ranked the third best department of neurosurgery of China. And we are also the WFNS postgraduate training center since 2016. We have 336 beds and over 100 doctors. The department was divided into 11 subspecialties, including skull-base, cerebrospinal vascular disease, glioma, functional neurosurgery, stereotactic radiosurgery, and neurointervention, vertebral spinal disease, and pediatric neurosurgery and trauma in ICU IOM. And back to 2025, our annually workload of the open surgery is 11,020 and 4,766 interventions. Let's look at this kind of a case series. Well, most of this tumor have a different origins, but the morphological center is in the posterior clinoid. There are several different definitions for these tumors, but Professor Zhang Qingting and differentiated to a Spheno-Petro type of tumor, which involved the zone 1, 2 to 3. And Professor Kawase had defined as a Spheno-Clival type. And later, he had also some article presented the post-clinoid meningioma, which is a morphological center of this tumor. The surgical approach for these tumors, we need to take consideration about this exposure, of course, because it's a meningioma have a tumor base. We need a sufficient exposure of the tumor and also the maximally safety resection to preserve all the nerves, the vasculature, and brain. And also we wanted to resect the tumor under direct vision. And also we wanted to be minimally invasive because most of the cases would take a long surgery. And for this tumor, today we'll talk about many types of tumor where the lower boundary is above the IC line. Well, the first common approach for this tumor, we could use the anchored bipolar cautery to use this devascularize the tumor, have a limited extent to the superior clival portion. But this is a completely blind maneuver, which is if tumor have extended to the dural canal, you may harder the abducens nerve. The second approach, we could use a combined approaches. We use the terional OZ approach, combined the anterior posterior approach to get access to this full tumor base of the tumor. But this will take a more traumatic and time-consuming. For patients have not eye movement disorder, we need to apply the Dolan 60 or 70 approach to complete the decompression for the oculomotor and abducens nerve, so we can relieve the patient's symptom. But this also is more traumatic, time-consuming. Only suitable for the patient have a cavernous sinus invasion and cranial palsy. And also we can stage in the treatment. We can use a terminal approach for the first stage to resect most part of the tumor. And we can use the second stage, we do a retrosigmoid approach, or use gamma knife, or just observation. But this may take a risk of tumor growth. The microscope and endoscope are very powerful surgical tools for our neurosurgeons. We should master most of those tumors, this technique. And the microscope, we have a optical clarity, have a very true 3D visualization, and very efficient micromagnification under the microscope. But it also have a limited depth of field and inadequate depth of field when they have a very deep field, surgical field with illumination. And we also have a limitation for the ergonomics because we have to adapt for the position of the for the microscope. So sometimes I will use the oscilloscope to do the surgery. And for the endoscope, we use have a better close-up observation and a wide-angle field of view. And we can also use a 30 or 40 or even 70 degree of angle scope to visualize the dark side of the surgical field. But when we operate under endoscope, we have a posterior blind spot. Sometimes we're taking risk to the vital structures, and also take a time to the training adaptation for the microsurgical manipulation under endoscope. And talking about the combination of the microscope and endoscope, there are two aspects. We can use a combined equipments, and we can use the combined approaches, which is the commonly combined transnasal approach with the transcranial approach. Today, we are only focusing on the combined equipment. With a combination of the microscope and endoscope, the classic terminal or OZ approach can be augmented. So we can simplify the approach and have a radical management of the tumor base. To complete this this combined approach, we need a spacious surgical corridor and has a sufficient sylvian fissure opening and sylvian detachment. And also we need to untie the oculomotor and trochlear nerves, and also remove the barrier between the middle and posterior skull base, which we need the posterior clinoidectomy and anterior petrosectomy sometimes, with angled endoscope and instruments, and also a endoscope holding arm. And we can use the staging attachment techniques for the sylvian veins, which we covered this topic on my last presentation. And we need to use this very narrow corridors between the on both sides of oculomotor nerve. So we need to have a complete detachment for the oculomotor nerve. And sometimes we need to detach for the trochlear nerve. The challenging skull base surgeries like mountaineering, which is the summit of the skull base mountain, is a posterior clinoid process. To traverse across the mountains and valleys in such procedure, one must embody the spirit of foolish old man removes mountains. This is a perseverance from the ancient Chinese legend that conquers even the most daunting challenges through unwavering determinations. So if we wanted to cross the valleys, we need to move part of the mountains to have a easy access from the anterior and the middle skull base to the posterior skull base. So we need anterior posterior clinoidectomy, and also a angled endoscope and instruments, including scissors, bipolar cautery, and some dissector. Of course, because we need to work behind those vital structures, so we need a holding arm, steady holding arm to help us to fix the endoscope. This is a case illustration. This is a 56-year-old female with left visual impairment for 3 years. Well, for this case, we have some surgical strategies, including the arteries, veins, nerves, bones, and approach, and the concept reconstruction. For this patient, the left ICA, MCA, AC, and the phenotype PCA were completely encased by a tumor. And we told the patient to have 3 months covered the compression training. The BOT came out positive, so the revascularization technique should be prepared. And also the perforators from the PCA, anterior choroidal, superior hypophyseal artery, and anterior perforating arteries were properly enwrapped by a tumor. Well, those small tumors are giving a blood supply to the cortical deep nuclei, fiber tract, optic nerve, and optic tract. The blood supply of the optic tract is supplied by the thalamic perforators of the posterior cerebral artery and branches of the anterior caudal artery of the internal caudal artery. In rapid, this vital perforators may cause the patients have some deep nuclear stroke. So we need to preserve all the small branches. And we use the interdural dissection technique to minimize the disturbance of the venous drainage. But the patient in the left eye was almost blind, early and multiple size decompression for the optic and oculomotor nerve was planned. We can see the roof of the cavernous sinus was invaded, so the third, fourth, and weaver nerves may be entangled. And because the tumor had extended inferiorly to the middle clivus, so the sixth nerve was probably involved by the tumor. And the skull base reconstruction CT scan revealed the bony hypostosis between the anterior and the posterior clinoid, which were the origin site of the tumor, and possibly a bony bridge was formed between those two clinoids. So, because of the possibly bony bridge, we could not perform the completely and extradural approach for the clinoidectomy. We need to do the staging, combined extra and intradural clinoidectomy to safely remove the tumor, the clinoids. And we use a 2-piece OZ because the IC encasement and cavernous sinus invasion and clinoid hyperosteosis, so we choose the extradural and intradural combined optic canal decompression and anterior clinoidectomy. And also we need to apply it for the posterior clinoidectomy. Well, the gross total resection was planned, but the actual resection degree depends on the interface of the neurovascular structures and tumor stiffness. Our primary surgical goal is to preserve neurovascular structures and functions. Well, we use the 5D algorithm for the decompression. In addition to the commutative 4D, we advocate the early decompression for the oculomotor nerve and optic canal optic nerve. Because of multiple dural incision at the skull base, a multi-layer dural reconstruction was applied for this tumor. This is incision, patient position, and IOM setup. Well, this is a microscopic phase. We use a mobilize the dural propria on the lateral wall of cavernous sinus and partially drill the anterior clinoid and decompress oculomotor optic canal and cut the falciform ligament and already decompressing the optic nerve. And we can see the ophthalmic artery, and we can see the hyperosteosis of the anterior clinoid. Now we have a crossing control of the carotid artery and split the Sylvan fissure and open the Sylvan fissure and the intradural staging of the anterior clinoidectomy to see a very sharp edge of the anterior clinoid. And expose the MCA, retrograde dissection of the tumor, and cut the tumor into lateral and medial portion. And then we continue to decompress the optic nerve, which is we point D to dissect the anterior cerebral artery, and continue to dissect the tumor. We can see a complete enwrappment of the anterior perforating arteries. Those small tumors, small perforators were vital structures to preserve the patient's visual function. And continue to dissect the fetal type PCA. And we could see the complete enwrappment of the anterior carotid artery. And you can see a very strong enwrappment of the tumor. Those vital perforators supplied to the deep nuclei. We continue to dissect the perforators, and this is encasement of the anterior perforating artery. Well, to release this artery, we need to find the original encuffed plane. So untear the perforators from the tumor. And then we go back to the optic co-oculomotor triangle, and to preserve the anterior hypophyseal artery. Besides the mechanical decompression for the optic nerve, we need to preserve those small branches. And then we can see some remnant tumor here, which is behind the caudate artery. This might be the small blind spot for the microscope. We will deal with it later. And then we located the oculomotor nerve to decompress the oculomotor nerve. And then continue to decompress the tumor. And then we do the posterior clinoidectomy to have better access to the clivus. And we see some invasion of the roof of the cavernous sinus. And then we have only left for the clival portion. We induce the 30-degree endoscope. You see we have a completely removed the posterior clinoid. We have a very direct access to the superior clivus. This is abducens nerve with sharp dissection to dissect this nerve, and this is oculomotor nerve. And we go back to the second space. We can find some remnant tumor behind the caudate artery. With the visualization of the angular endoscope, we could completely resect this part of the tumor. This is basilar artery, endoscope and microscope view after the resection. The oculomotor nerve, this is superior hypophyseal artery, and the final view. The ION was normal. We use the multi-layer suturing and exhaust the air. The post-op MRI showed the complete resection of the tumor. The patient recovered with transient sternal palsy and visual function improved. The pathological investigation confirmed grade 1 meningioma. This is another case of a small size tumor, but for the small size we have a more narrow working corridor. But still, this tumor have a oculomotor caudate artery encasement and superior clivus extension. This is also a Tenorian approach. After the microscope phase, we induce the endoscope to still find a way to visualize this superior clival portion of the tumor. They have a completely resection of it. Because this patient didn't have a eye movement before the surgery, so we didn't give the patient abdominal approach, have some remnants inside of the cavernous sinus. This is another case, have also a caudate encasement and some lateral extension of the tumor base. So for this patient, we need also an extradural optic canal decompression, and anterior clinoidectomy and posterior clinoidectomy. After resection for the most part of the tumor, we need to decompress oculomotor nerve here, and then continue to dissect the trochlear nerve to have a better working corridor for this tumor in the superior clival portion, and induce the endoscope and devascularize the tumor with direct vision. Here I'm trying to find the trochlear nerve, the abducens nerve here, is here. And the trigeminal nerve is visualized in this part. I use angled scissors and suction device to decompress this part of tumor, and you can see some invasion of the microscope. We need to mobilize the trochlear nerve. And cauterize this part. This is trigeminal. This is abducens. This is abducens nerve. The oculomotor, trochlear, and abducens nerve. Basilar artery. The patient have a neurototal resection and a transient thermal palsy. It's the atypical meningioma we give in radiation therapy. Another case, it's a 33-year-old male admitted with right visual impairment for 8 months. The MRI scan revealed a central scopus lesion originated from the posterior clinoid. Also have some encasement and adhesion for these vital vasculatures. Also some cranial nerve involvement. For this patient, we need a sphenoid ridge, complete drill of the sphenoid ridge and extradural anterior clinoidectomy, and extradural optic canal decompression, and bilateral posterior clinoidectomy to have access to the bilateral superior clival portion. These patients. First, also a microscope phase, we incise the MOB to mobilize the dura propria and perform anterior clinoidectomy and optic canal decompression. And open the dura and cut the falciform ligament and visualize the optic nerve and carotid artery and oculomotor nerve. Also need to decompress because the tumor was pushing the nerve front, and need to devascularize the tumor, and you see the oculomotor nerve. And this is a trochlear. And continue to devascularize. You can see some encasement of the perforators and the caudal artery, anterior cerebral and little cerebral artery. Some numerous encasement of the tumor, but the tumor is soft, have a very good interface for us to preserve these arteries. And continue to dissect and decompress this tumor. And jumping from different corridors, different windows of these perforators. Anterior porphyrin artery is here. And take times and patience to preserve all the small arteries. And this is the superior hypophyseal arteries, also very important structures we need to preserve. We want to preserve for the visual function for the tumor. This is a stalk, and devascularize the left posterior clinoid, and deliver tumor to exposed bilateral posterior clinoid. The trioid posterior clinoid, this is a posterior gland of the pituitary gland, and left posterior clinoid. And after the devascularization, we need to continue to dissect the contralateral oculomotor nerve, the trochlear nerve contralateral, the pituitary stalk, the contralateral P-col, and the basilar artery, and preserve the lytic crystal membrane, and deliver the portion of the tumor. And this is a remnant clival portion of the tumor. We induce the 70-degree endoscope. This is a clival dura. You see the contralateral abducens nerve. And this is an ipsilateral trigeminal. And the ipsilateral abducens nerve is completely encased by the tumor. We use the encode, this knife, because it's far beyond my scissors to reach this part of the tumor. Use curved dissector and release the tumor. This is from the view, the contralateral abducens basilar, the oculomotor nerve, the superior hypophyseal artery, the ICA, ACA, anterior porphyrian artery, oculomotor nerve, and the IOM was normal, and the Pulsatile dura closure. This is a post-op CT scan. We see a completely removal of the anterior clinoid and the bilateral posterior clinoid. The post-op MRI revealed the completely resection of the tumor and a half-year follow-up here. The patient had a transient cerebral palsy, and the patient's vital function improved after the surgery, and pathological investigation confirmed the grade 1 meningioma. And for those tumors we're talking about is reach the upper and middle clivus, because the tumor had only extended to the middle clivus. But how about the step further? This is a 53-year-old male with a left ptosis and the left hearing loss for 2 months. You can see a giant Spheno-Petro-Clival tumor. And the patient see the tumor has reached to the inferior clivus and the involvement of the inferior IAC. For this patient, we induced anterior petrosal combined with the lung approach. Because the patient had ptosis, we need to completely decompression for the oculomotor nerve and also including the trochlear and abducens nerve. We planned extradural optic canal decompression and anterior clinoidectomy and posterior clinoidectomy, plus then anterior petrosectomy. And first we drill the anterior clinoid and have an optic canal decompression. Then we completely drill the anterior petrocepex, and starting from the trochlear nerve to decompress this nerve and open the Microscopic dura, and this is the oculomotor nerve. Continue to dissect to release the trochlear nerve here and release small part of tumor, and continue to decompress for the oculomotor nerve. This is a trochlear. The patient, you can see the tumor had a infarction because we have a previous embolization for this tumor. our vascular guys did a very good job to minimize the vasculature of this tumor. And this is a brainstem, have a strong adhesion. And continue to dissect to preserve those. This is a PetroClival. We posteriorly immobilize the trigeminal nerve and to drill the PetroClival is a Cooper's ligament. After drilling of the PetroClival, and we release the abducens nerve here. And they continue to dissect it as a contralateral trigeminal nerve and the contralateral abducens nerve, ipsilateral abducens nerve, completely decompress for that. This is a complete Dolungus 70 approach. Then we induce a 70-degree endoscope. We can see some remnant tumor in the inferior clival portion. And mobilize the abducens nerve to have a different corridor to visualize and devascularize the tumor. And decompress and release, devascularize with the tail sign. And there's a final view. You see this is IC, the cranial nerves. The final view. And the post-op MRI scan reveal the neural total resection of the tumor. We can see some remnant inside of the cavernous sinus. And the patient had a sternal palsy recovered and 3 months follow-up. The patient pathology result confirmed the atypical meningioma. We suggest the radiation therapy. The patient did not follow our instruction, and this is 1 year follow-up. So we put him under observation. The result, starting from the first case in 2019 to now, we have 14 cases of this combined microscope and endoscope approach. It's not much according to our volume because most of the cases we could use a single approach without a combination of the endoscope. Only use a microscope, we can visualize most part of the tumor base. And have 3 cases where gross resection and 11 cases had a neural resection. Most of the remnant were inside of the cavernous sinus. All the patients have a transient sternal palsy, and 1 case with transient hemoptysis because compromise of the perforators have 0 mortality. And for conclusion, the combined microscope and endoscope technique, the introduction of the endoscope extends the view, thereby enhancing the surgical capabilities. Although a thorough understanding of the characteristic of both microscope and endoscope allows for optimal utilization of their respective advantages. And the endoscope will expand the exposure of the classic surgical approaches and simplify the surgical access. We need adequate bone removal and nerve decompression. Those are essential to create a sufficient operating corridors. Of course, we need to practice in the lab and take it over and back to the lab to resolve the portion and the problems. This is our Department of Neurosurgery in West China Hospital, our skull-based center. Thank you for attention.
Thank you very much for your very beautiful surgical video, especially For dissection, the perforator from the tumor is very nice, fine procedure. Thank you very much. And any question from the audience?
Yes, of course. I would like to ask first of all, let me thank you for this wonderful demonstration of wonderful technique that you have shown us. You are more or like of an old school, the scissors and knife. I like that because I am also old school. I've seen such dissections. Yeah, classic dissections. I didn't see more of the CUSAs and other gadgetries. Why don't you use CUSA?
Actually, I use a lot. I use a lot of this ultrasound aspirator because I think because those surgery is most prolonged, so I just edit in. Just didn't edit in the surgical video, but CUSA is important. I usually use CUSA with this intraocular projection with a the navigation system, so we could minimize our surgical duration. That's important, the CUSA. But near the vital structures, we need to change to the scissors and suction to use sharp dissection. CUSA just save a lot of endeavor.
Right. Thank you very much. As Dr. Ben has raised his hand. Ben?
Yes, and thank you, Professor Xin Zan, for your great presentation, and I'm happy to see you here. And just a simple question. I want to ask how do you choose the cases for preoperative endovascular embolization for this meningioma? How do you choose preoperative?
Yeah, actually, I want our vascular guys to embolize every case, every giant tumor. It's not my option to choose. Most of it choose by my vascular guy. I will send them to DSA to find out the vasculature. If they get access to the blood supply of the tumor, my vascular colleague will try to embolize feeders. Sometimes they take a lot of time, but I always communicate with our vascular team. So your work means a lot to me, because if you can take in those feeders, will give me much more bloodless surgical view, so I can visualize the vital structures, the nerves, the feeders. We have a better visualization. That's your work is mean a lot to me, mean a lot to the patient. So I encourage them to the thorough embolization. I think it's very important, because some of them, they think they've taken those feeders is not important, but actually means a lot.
See, thank you so much.
Okay, thank you. Professor Guevara, you may ask.
Yes. Before this presentation, I had saw the combined surgery being combined with endoscope from the transnasal and open surgery.
Yeah.
But you're combined mean the same, using the same corridor, right? And
yes.
Usually for me, to decompress, to resect the tumor around the 6th nerve, abducens nerve, I usually use a transcavernous approach or the antepetrosal approach to approach to the Dorenos canal. But your surgery, like using the endoscope, you can see the Dorenos canal from the anteriorly. But which space do you use to insert the endoscope, like between the southern carotidity or southern fourth nerve, or like fourth nerve and like Parkinson's triangle? Which corridor?
Yeah.
Maybe the first.
The corridor I use is actually the corridor of the tumor. and mostly
yeah,
behind,
Mm.
between the choroidal artery and the oculomotor nerve. Most of the case I use this choroidal because they were giant tumors. After resection, most part of the tumor will have a very wide surgical exposure, and the oculomotor nerve is completely detached from the dura. So I have a very wide choroidal to place the endoscope and another two instruments to working in the narrow space. Yeah,
But
most of
what
them
size?
use that.
What size of the endoscope?
Just a normal transnasal. It's a 4 millimeter transnasal. Okay. Yeah, transnasal endoscope.
Actually, 4 millimeter endoscope is, I think, it's too big to insert between the carotid artery and the oculomotor nerve. So, for me, I usually dissect the side nerve from the dura. I mean, open the oculomotor cave, and also open the cavernous sinus. I mean, the transcavernous sinus. That can make the space bigger and easily insert the endoscope on the instrument. So do you open?
Yeah. I very cautiously choose the patient who to do the extradural feeding of the microscopic dura, because normally this took a lot of time and surgical goal is limited. So for patient we have an eye movement disorder, means all the cranial nerve need to be decompressed. So I choose the Dolank approach to decompress all the nerves. But this took a lot of time. So for the patients didn't have this pre-op symptoms, I only just choose to preserve this precious surgical plan. If the patient have a tumor regrow, I will do a more extensive approach for this tumor. And 4 millimeter actually, I think is pretty enough because we gain the space from the tumor. We resect most of the tumor, and we have a more solid space to resect this tumor. Sometimes I even use the 5 millimeter because the 5 millimeter have a bigger lens, have a more great visual quality to working under this endoscope. But 4 millimeter is enough. If it's a very narrow space, we could use a 2 millimeter. Usually for the child, we have a 2 millimeter endoscope. It's also used for inspection and guided operation.
Okay, so your endoscopic view is very beautiful and very clear. Clearly, we can see the 6 nerve canal. I was surprised.
Yes.
Very nice.
Yeah, it could be done. Yeah.
Okay.
Thank you.
Thank you very much. So with that, we come to the end of today's session. I'll close this officially now. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both the speakers today, Dr. Mohammad Abdalkader and Dr. Xin Zan, as well as the Chair, Professor Takashi Sugawara, for taking out the time and support for the ACNS webinars. Very special thanks to co-host Liu Bun Seng and also Ben for joining us today, and a special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, there are around 730 people who have logged in through all the different channels. So until we all meet online tomorrow, it is bye bye from all of us. Thank you very much for joining.